Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Thanks for tuning in to episode 13 of the Super High Yield Anesthesia Podcast, and we're continuing our adventures into trauma anesthesia, well, part 5, and today we're going to focus on burn management. So to give you a quick overview of this episode, first we're going to talk about the anatomy of the skin, then we're going to talk about the different types of burns, then we're going to move on to talking about the physiologic changes that occurs during burn injuries, the types of burn injuries, how to estimate burn surface area, and lastly, we are going to talk about management of a burn victim. Okay, so if you have the time, I would really appreciate it if you fill out the pre-survey for this episode, but if not, that's all right. If anything, I hope you learned a lot today, and let's get to it. So we're going to start off with a quick anatomy review of the skin layers. And generally speaking, there's 3 layers to the skin. So there's epidermis, dermis, and subcutaneous fat. And that's from superficial to deep. All right, now we're going to talk about the different types of burns and burn severity. And this is kind of helps us determine the severity of the burns. So again, there's first, second, and third degree burns. Okay, first degree burns usually just involves the superficial aspects of the skin. It does not penetrate the epidermis. So things like sunburns or superficial thermal injuries are classified as a first degree burn. Second degree burns are partial thickness injuries that actually does penetrate the epidermis and actually extends into the dermis with associated blistering. And just a quick overview of treatment, things like fluid replacement therapy if it's greater than 20% of the total body surface area. And these second degree burns possibly require skin grafting. Okay, so that's second degree burns. And lastly, we have third degree burns. And this is full thickness burns. And this is basically full thickness of the dermis. And then you're exposing the nerves, blood vessels, lymphatic channels, and other deep structures. And those are going to be damaged in third degree burns. It's important to note that these are very painful, and treatment for these generally will require debridement and skin grafting. So again, first degree burns, superficial, does not penetrate the epidermis. Second degree burns, partial thickness, which penetrates the epidermis and extends into the dermis with blistering. And third degree burns are full thickness and extends all the way down. It damages nerves, blood vessels, and other deep structures. Okay, next we're going to talk about the different physiologic changes of burns, and this is going to be a very brief overview. And basically what we're going to focus on is cardiac output. In patients with severe burns, the cardiac output can actually decline up to 50% within 30 minutes of injury. And the mechanism behind this is due to burn-induced vasoconstriction. And basically, you're inducing normal volemic hypoperfusion. So this is basically classified as burn shock. And this is the reason why these burn victims will need to be fluid resuscitated. And the cardiac function, it generally returns to normal within 48 hours, but this can be very dynamic considering as the patient heals, there's different metabolic needs for the patient, and then the physiology might change as well. So it's going to be like a case-by-case basis, but it's important to note that you should expect dynamic changes in the hemodynamics. Okay, next we're going to talk about the different types of burns and the considerations and treatment for these burns. So 3 different types are going to be chemical, electrical, and thermal burns. So for chemical, so for example, if a patient works at a chemical plant and then they get whatever chemical on their body, or they work in a lab or something and spill it on themselves. So what you want to do as a first line of treatment is to basically irrigate the area that's been affected. And basically you're going to continue that irrigation until the skin pH or the fluid pH it's going to be neutral. You check this using litmus paper. And when you're doing this, the key thing is to try to prevent the irrigation fluid from touching unaffected skin, because basically you don't want to spread whatever contaminant to normal healthy skin. And if you're able to find out what exactly got onto the patient, this will help you with the type of irrigation fluid as well. Because, for example, if a patient gets an elemental metal burn, so for example, getting burned by lithium, magnesium, or potassium, you don't want to use water for this, for irrigation, because if you've seen YouTube videos, if you're throwing these metals into water, it just explodes. So don't do that. So basically, when you know that the patient was burned by these elemental metals, use mineral oil as your irrigation fluid. Okay, next type of burn is the electrical burn. And whether the person was shocked by lightning or if they put a fork in the outlet or something, you want to look for entry and exit points and look for underlying muscle damage. And for these patients with electrical burns, they're at risk for compartment syndrome and rhabdomyolysis. So be aware of this as well. And patients that sustain electrical burns tend to require slightly increased fluid requirements. And lastly, for thermal burns, obviously, if they're still on fire, remove that heat source. So like their pants are on fire, take it off. You don't want that on them anymore. Okay, and you're going to continue prolonged irrigation with cold fluid, but you also want to avoid hypothermia at the same time. And basically, for these thermal burns, so if they're in like a house fire or whatnot, you want to suspect other injuries as well. So for example, inhalational injuries and other forms of trauma. So don't get distracted by the distracting injuries. Okay, so that's the 3 types of burns and the different considerations for these two in initial treatment. So chemical, electrical, and thermal. Next, and we'll kind of briefly go over this, is estimating burn surface area. And this is something super high yield for board exams. For example, things like shelf exams if you're a med student, or like COMLEX level 1, level 2, or step 1 to CK. So it's the rule of 9s. And this is a way to approximate the burn surface area so you know how much of maintenance fluid to give to the patient. And basically the rule of 9s is different parts of the body are going to be broken up into 9%. So for example, the upper anterior torso, that's 9%. Lower anterior torso is 9%. The upper back is 9%, and the lower back is 9%. And each arm, anterior surface is 4.5, and the posterior surface of the arm is 4.5. So total, each arm is 9%. The front of the face is 4.5%. Back of the face, or back of the head, is 4.5%, which makes the head as total 9%. And each leg is 9% anteriorly and 9% posteriorly. And lastly, the groin area is just 1%. So if that was super confusing, I wouldn't be surprised because I just threw a bunch of numbers out. But essentially, the main concept is the rule of 9s is breaks up different body parts in 9% sections. And it helps you calculate the body surface area so you know how much fluid to give to a patient. I highly encourage you to either take a look at the show notes or just Google rule of 9s so you get an idea of what these zones are and kind of be able to approximate the burn surface area because this is going to show up on your exams. Okay, so that was all like the business stuff regarding the characteristics of burns and how to approximate the burn surface area. And now we get to the fun stuff of management. So the first thing we're going to talk about is intravascular fluid management. And as I alluded to earlier, you're going to utilize the rule of 9 to kind of help you calculate the amount of fluid to give. So first of all, we're going to have to talk about fluid choice. So essentially for burns, the most ideal fluid is balanced crystalloid solutions. So for example, lactated ringer or plasma light. And you actually don't give colloids in the first 24 hours because they will be ineffective due to protein leak. So if it makes sense, because especially for severe burns, the cells are going to be damaged and it's just going to be leaking everywhere. So don't give colloids in the first 24 hours. The first 24 hours is usually resuscitated with a balanced crystalloid solution. Okay, now finally we're going to talk about calculating how much fluid to give. So the main two formulas that you can use are either one, the Parkland formula, or two, the modified Brook. So for the Parkland formula, it's basically 4 cc's times the total body weight in kilograms times the percent burned total body surface area. And basically that gives you a total volume, and you give half of that volume within the first 8 hours and the other half over the next 16 hours. Okay, so that's the Parkland formula. And for the modified Brook formula, it's basically the same thing except for you're basically reducing it in half. So for the modified Brook, it's 2 cc's times the body weight in kilograms times the burned total body surface area. And same method of providing the fluids, and you're giving half of that volume in the first 8 hours, and then you give the other half over the next 16 hours. And the main goal is to achieve 0.5 to 1 cc's per kilo per hour of urine output. And this is for adults. And before we move on a little bit, let's talk about pediatric considerations. Basically, it's the same protocol as adults. So you're going to utilize the Parkland modified Brook formulas. These total body surface areas, the rule 9s for pediatrics is a little bit different. So I'd encourage you to kind of just look it up before putting it into place. But essentially, it's more or less the same. But if the child weighs less than 30 kilos, you want to give 5% dextrose in the IV fluids, and your urine output goal is going to be 1 cc per kilo per hour. And it's going to be a little bit higher if the patient is younger than 1 year of age. So your urine output goal is going to be 1 to 2 cc's per kilo per hour. So you might be thinking, why are we so obsessed with calculating the exact fluid volume that you need to give, and you're giving it within a certain amount of time? So remember, half in the first 8 hours and the other half in the 16 hours. So there's a concept called fluid creep. And basically this is when you have an over resuscitation with fluids for these burn patients. And this actually leads to poor outcomes, because over resuscitation is associated with abdominal compartment syndrome and other complications like ARDS. So titrating the fluids is very tricky, and that's why there's specialized burn centers that takes care of these patients. But this is a concept that you need to keep in mind when you're trying to treat these patients. Okay, next, as part of the anesthesia team, we're obviously going to be concerned about the airway. So burns are associated with lots of erythema and rapid onset edema. So that's why we have to secure the airway early. And because of the edema, you want to consider 0.5 to 1 millimeter internal diameter smaller than you usually use for a certain patient to allow room for the swelling as well. So signs for potential airway burns are things like carbonaceous sputum, stridor, voice changes, facial burns, explosive injuries involving the upper torso and head, and prolonged entrapment in fire. And unfortunately, even if you intubate the patient, there are greater risk for pulmonary complication and resuscitation related complications, things like pneumonia, ARDS, and pulmonary edema, things like I mentioned earlier regarding fluid creep and whatnot. Okay, next, burn patients are extremely hard to control pain in. But generally speaking, opioids and ketamine are viable options, and you want to get the pain service of your institution on board as soon as possible, because again, these are very complex wounds and then requires a complex pain management regimen. Okay, next we're going to talk about inhalational issues, especially things like carbon monoxide and cyanide poisoning. And this is actually a very common board question, so something to pay attention to. And basically, if a patient has been exposed to burn injuries, it increases their exposure to things like carbon monoxide. And this results in reduction in the oxygen carrying capacity because remember, carbon monoxide, it binds to the hemoglobin much better than the oxygen. So you're not actually carrying oxygen to the tissue as well. And as you might recall, the most common signs for these things are like headache, bright red lips, the post-ox is only at 85% and it's not really improving. So if any of your patients have these symptoms in the setting of a burn sort of injury or they've been caught in a fire or something, suspect carbon monoxide poisoning. And interesting thing is the only way to actually detect carbon monoxide poisoning like directly is to get oximetry on the blood gas. And a high yield thing to know is that the treatment for carbon monoxide poisoning is high concentration of oxygen. So having really high oxygen supplementation. Okay, next, burn patients are especially high risk for infection. So you want to start them on empiric antibiotics, have sterile dressings for them, and definitely be careful with over-resuscitation because this actually could increase the risk for infection as well. Okay, next is escharotomies. And basically, eschars are damaged tissue that becomes really rigid and black. So eschars decreases the compliance of the body tissue, and this becomes dangerous when it becomes circumferential around a limb or something like that because it increases the risk for compartment syndrome. And something to really be concerned about if it's all around the abdomen, and this increases the risk for abdominal compartment syndrome. And again, this occurs with circumferential abdominal burns, and if the patient is receiving a lot of IV fluids that's basically greater than 6 cc's per kilo per percent total body surface area. And the way you can diagnose this is with an intraluminal bladder pressure in the Foley. And basically, if it's greater than 20 millimeters of mercury, they're going to need immediate abdominal cavity decompression. Okay, next is transfer of burn patients to a specialized center. Unfortunately, burn centers are not available in every single hospital. So there may come a time where you have to take the initial care for a patient and then transfer them to a specialized center. So there is a different criteria that needs to be met to consider transferring a patient to a burn center. So I'll just go down a list for you guys. If a patient has greater than 10% total body surface area partial thickness burns, it should be transferred. If they have full thickness burns in any age group, they have burns in sensitive areas, so for example, hands, feet, perineum, face, genitals, things like that. They have inhalational injuries, electrical and lightning burns, circumferential burns, a significant chemical burn, or patients that receive burn injuries and have major pre-existing comorbid conditions. So those are the conditions in which you should consider transferring your patient to a burn center. So the last thing we're going to talk about is the anesthetic considerations. And the three main topics we're going to talk about for burns is temperature regulation, airway, and analgesia. So for temperature regulation, there's a few things that you want to do for these patients. One, you can use radiant warming. Two, you can use forced air warming devices. Three, they're fluid warming devices. And four, the burn care environments are usually at 40 degrees Celsius. So maintaining temperature for these patients is going to be very crucial. Regarding airway, like we mentioned before, indications for intubation are things like hoarse voice, dyspnea, tachypnea, and altered mental status. And regarding induction and choice of induction, within the first 48 hours, you actually could use succinylcholine. But anytime after the first 48 hours of initial injury, you should not use succinylcholine. And this is because the injury and disruption of neuromuscular end plates, it actually upregulates the acetylcholine receptors. So if you use Sux after the 48 hours, it could actually cause lethal hyperkalemia. So definitely don't do that after 48 hours. And the interesting thing is that this risk can actually persist up to 2 years after a burn injury. So if you're aware that a patient has a burn injury in the past, definitely ask them how long ago it was and keep that into consideration when you're choosing an anesthetic regimen for these patients. And these are actually very high yield board questions, so definitely something to remember. And lastly, for analgesia, as I said previously, these are very complex pain patients. So getting the pain team on board, because they could develop opioid tolerance very quickly. And you should also consider the psychosocial complications of these burns. And lastly, one of the options you can use to control pain is regional techniques. Okay, thank you so much for sticking to the end of this episode. I hope you were able to pick up a few things and at least keep a few tidbits in mind when you get like a board question or something like that. So yeah, the fun fact I have for you today is Sudan has more pyramids than any country in the world, which you would think that Egypt would probably have it, but Egypt only has 138 known pyramids and Sudan has about 255. All right, guys, thanks again for tuning in. If you have the chance to do the post survey, I would really appreciate that. And I would love to hear from you guys. So if you would like to connect with me, I have my social media links in the description. And I'm always down for any show ideas that you want to hear or any suggestions on improving the podcast. I would definitely love to hear from you. All right, so all of that said, this is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.